So we have one more speaker before the Q&A. I'm really pleased to introduce Dr. Neliswa Gogela. Dr. Gogela is a hepatologist at Gogela Hospital at the University of Cape Town, and she's here today to talk to us about HIV and hepatitis C care for women who use drugs. Welcome.
Thank you so much for that short and sweet introduction. Good morning, everyone. What a powerful and an inspiring morning. In my language, we say, "Wathinta umfazi, wathinta imbokodo." In English, it translates, "You strike a woman, you strike a rock." We are powerful. So, my disclosure, I am not a scientist, I am a clinician. And so I look after sick people, but I do love science. I was tasked to talk about HIV and hepatitis C care for women who use drugs, and I'd like to thank the organizers for their invitation. So I'll just jump right straight to it. According to WHO, we still have a problem. We've got about 50 million people who are chronically infected with hepatitis C, and despite having DAAs, we still see about 1 million new infections. HIV is close, and our continent is the most affected. Owing to shared routes of transmission, it is not uncommon that you see dual infection, in fact, sometimes triple infection with hepatitis B. Of the estimated 11 million people who use drugs, half of them have chronic hepatitis C, and 1.2 million are co-infected. The ratio men to women in people who use drugs is 4:1. But women, as we've heard, they face a range of gender-specific, often challenges and huge barriers. 2016, the WHO had dreams. This was shortly after the discovery of the DAAs that cured hepatitis C. These dreams included clearing viral or eliminating viral hepatitis through reduction of mortality, reduction of new cases, but most importantly, treating about 80% of people that are chronically infected. Recently, there was a systematic review that looked at what we've done pre and post DAAs. The estimates and the numbers were interesting, but our continent and Southeast Asia is lagging behind. Just to put it in color perspective, as you can see, the majority of the data was from European countries, very little happening in Africa. And majority of those estimates, or some of the estimates that were from the European were direct estimates for hepatitis C. Post-DAAs, we see some activity in Africa, Nigeria and Libya, showing trends that they are doing something about hepatitis C. If you look at countries that form the top 20 in numbers, you can see that USA is leading the pack, but South Africa is in the top 10. Who are these people that are actually affected hepatitis C? It's shown that we've got a bimodal age distribution, the millennials, and significant is these are people of childbearing age, and the baby boomers who usually have chronic infection. If you look at gender, as I've mentioned, the ratio is 4:1. But you can see and appreciate that this majority of women of childbearing age that are chronically infected with hepatitis C. What is happening with South Africa? This was published recently. I think the authors are in this room. They looked at networks of people who use drugs in 4 provinces within South Africa. And as you can see, we're still seeing a lot of people who are affected by HIV. What was interesting, though, that even though we had about 40,000 people, only 2/3 of these people had records of HIV in their data. I want to introduce you to a young lady that I met recently, a woman that I could relate to, because just like her, I am actually a product, or I am proudly a daughter of a mother who struggled with substance abuse. Miss FL is 31 years old. She's a mother of 3. Her firstborn is 16. She's got a 9-year-old and a 3-year-old. And we met her when she lost her last pregnancy, when she presented with liver failure, presumed from acute hepatitis C. Now you'd know here that this is a very rare phenomenon. She told me she started using at the age of 16. Mostly she smoked, but only started injecting drugs in the past 2 years. She was referred to Grooteskier Hospital, which is a tertiary institution, for workup for a liver lesion and treatment of hepatitis C. As you can see, she had a good going hepatocellular injury and she was deeply jaundiced. She was HIV negative. They'd done virology and she had come back with a positive hepatitis C antibody. We confirmed that she had viremia, but we still had to work out what was happening with those lesions in the liver, and I'm sorry for that light that's taking the spotlight of those lesions, but you can see, can't really point, you see that she's got multiple lesions on the liver, which we biopsied, and they turned out to be benign. So to her relief, we shared the news. She disclosed that she wasn't even aware that she was pregnant. She was admitted in a secondary hospital and only woke up 5 days later. By the time we saw her, she had fortunately cleared the hepatitis C and therefore didn't need therapy. She discussed rehab because she mentioned that this was the scariest time for her. So why are women at risk? And I think you spoke to that beautifully. Women are vulnerable gender. As strong as we are, the world is about the survival of the fittest. Women are prone to gender-based violence, usually are the last in line. They are prone to physical and sexual violence, and hence the risk of sexually transmitted disease. There is significant lack of women-targeted treatment and services, especially harm reduction. And women, they fear to lose it all. You disclose you use drugs, you lose your children. Remember Miss FL? She was taken from her biological parents at the age of 6. Both her parents used drugs, and her father sexually assaulted her. For 10 years, she says, she had a normal life, but when she turned 16, she found herself homeless. Her boyfriend, or then father of her firstborn child, was using drugs, and therefore, longing for love, for belonging, she started using drugs. Sexual assaults became a norm for her, something that she said I had to live with and couldn't report because these were people that were in my circle of drug use. Since the scare of possible death and cancer, she's joined a rehab closer to her home. She's found a network of strong women that support her. And when you ask her what she wishes for the most, is that her daughter, who lives in the same neighborhood, is spared from the trauma and the troubles that she has endured. She looks at her and she says, she's just like me. At 16, I had started using drugs, and she is surrounded by people that are using drugs. So she follows up with us, and she has a lot of support from the families that have adopted her 3 children and the network of women she's met in the rehab. So screening and testing and treating for hepatitis C and HIV during pregnancy, it is recommended, but it's not routinely done, and I'll show you proof that it's actually not routinely done. The recommendation is that every adult, whether high risk or low risk, should have at least one hepatitis C antibody. Every pregnant woman should have an HCV antibody, and people at risk of being infected with hepatitis C should be screened regularly. So have we? Do we? Here's another lady that we've met. She's 42, she's got 3 children, she's from Congo. We met her when she was 34 weeks pregnant. She had presented with pruritus, and she fitted the criteria of intrahepatic cholestasis of pregnancy, and we were called in to just start ESO, deoxycholic acid. She had been screened for HIV and hepatitis B, but never had hepatitis C. She had modestly raised enzymes, and she had a positive hepatitis C antibody. But look at that viral load. Was about to deliver, never tested for hepatitis C. This is her 4th pregnancy. We started her on Sofvel. Her husband and her children were screened. She had no significant fibrosis, and therefore we didn't need to follow up. And to date, tested her last week, she was cured. So why Sofvel? We have it in South Africa. It covers all genotypes. It's got very high cure rates. It's well tolerated, even in the setting of infection. There's not much drug-drug interactions. It can be safely used even in patients who are on PrEP. Note, in patients who are co-infected with hepatitis B, co-treatment and close monitoring for flares is mandatory. Drug-drug interaction can easily be looked up on this app. There's a young gentleman there who's advertising this. It tells you exactly what you can and cannot use. Where you see yellow, it means use with caution or monitor that patient closely. And I add there in the middle that for those patients who are on PrEP for HIV with lenacapavir, you can safely treat them with the DAAs. Is it safe to treat these patients during pregnancy? The answer is we don't know. There's no consensus. Between the ASLD and the EASL, they say use your clinical acumen, as we did with our lady who was about to deliver with a very high viral load. The recommendation, though, is that you start post-organogenesis or in the 2nd or 3rd trimester. There are few studies that have been done in pregnant women. As you know, that it's difficult to conduct trials in pregnant ladies, but they're promising. No babies were harmed, and almost all of those mothers achieved SVR. So screening for hepatitis C is easy. The recommendation, again, you treat it 2nd or last trimester, but don't forget to screen the baby at 2 to 6 months. Directed care for women who use drugs. One needs to understand that the journey is complicated by fear and stigma and a fragmented healthcare system. One needs to understand that these women are mothers first and foremost. We need to be mindful of the misconceptions as clinicians. Long-term support should include OATs, peer group support, family-centered and trauma-informed care. Enkosi. Thank you, everyone, for listening.
Thank you so much, Dr. Gogela. Please take a seat, and please feel free to come up and ask questions. There are 2 microphones at either end, and you're welcome to put your questions in the Q&A.